Give me a minute. Well, then, over there now. Right, okay. Right, so we have this question, third stage of labor is managed actively to prevent postpartum hemorrhage and uterine inversion. Which of the following is most important step to prevent uterine inversion during active management of the third stage of labor? I put this question mainly to revise the active management of third stage of labor because it can come over and over again. So the first step is intravenous injection of 5 units of oxytocin with the delivery of the anterior shoulder. We can also give ergometrin, but nowadays it's not given because there are certain complications like vomiting associated with ergometrin. So the first step is to inject 5 units of oxytocin with the delivery of the anterior shoulder. Then we deliver the fetus and hand over to the baby, to the midwife. The next step is to palpate and see whether the uterus is hard. That's the next step. If the uterus is hard, we apply control cord traction to deliver the placenta. It's not essential to wait for signs of placental separation before application of control cord traction. The most important thing is application of control cord traction to deliver the placenta only if the uterus is well contracted. So first step is to give oxytocin 5 units IV with the delivery of the anterior shoulder. Then once the delivery is completed, palpate the uterus to see whether it's well contracted. If it is well contracted, apply control cord traction. And finally, inspect the placenta and membranes for completeness. So the most important thing is to prevent inversion is application of control cord traction only if the uterus is well contracted. Because if I have told this, I have shown this to you, if you attach a placenta to a piece of paper and pull, it will invert. But if you attach a placenta to the table and pull, it will not invert. So the most important thing to prevent inversion of the uterus is to make sure the uterus is well contracted before we attempt to deliver the placenta. So there are several steps here which can prevent inversion of the uterus. First thing is what happens when we give oxytocin with the anterior shoulder. It causes a very strong uterine contraction, which causes not only expulsion of the fetus, but it causes almost immediate separation. It causes separation of soon after the baby is delivered. It causes separation of a normally attached placenta. So that means when you give oxytocin with the delivery of the anterior shoulder, by the time the baby is delivered and handed over, you anticipate that if the placenta is not morbidly adherent, it is well separated. Therefore, if you deliver a placenta that is separated, it will not cause inversion of the uterus. So the first step to prevent inversion of the uterus is to give oxytocin 5 minutes IV with the anterior shoulder to cause good contraction of the uterus. Next step is we have to make 100% sure the uterus is well contracted. Therefore, we palpate the abdomen to make sure the uterus is well contracted. That is the most important step. Third step is the application of control contraction. So what do? You push the uterus up with the ulnar border of the left hand placed above the symphysis pubis. So that will prevent inversion of the uterus. And you only apply gentle traction on the top. So these are the things that prevent inversion of the uterus. But the most important thing is to make sure uterus is well contracted before apply control contraction. What about waiting for signs of placental separation? It's not absolutely essential because again, it's only signs of placental separation. We haven't seen the placenta, whether the placenta is fully separated. What are the signs of placental separation? Gush of blood and the cord becomes longer. And when you push the uterus up, cord doesn't go up with it. These are the three signs of placental separation: gush of blood, lengthening of the cord, and when you push the uterus up, the placenta doesn't. When you push the uterus up, the cord doesn't go up with the uterus. Hello. යන්න බැරි වේ වගේනේ. මම මේ ඉස්සරහට දෙයක් යන කෝල් කර ආන්සර් කරනවා. මේ විදිහට තිබ්බොත් නෑ යන්න බෑනේ තේරුමක් නෑනේ දී අපා මෙච්චර ප්ලෑන් කරලා. මෙච්චර සතුටින් ඉඳලා යනවා කියලා යන්න විදියක් නෑ නේ මෙච්චර දවස් වලින් ඉඳලා යනවා. භූමිය වහිනවනේ ඕකාලා මොන භූමියද? ඕකාලා වහිනවා. අපරාධයක් මම බැලුවා මුළු සතියේම ඊළඟ සතිය වහිනවා. බලමු. දැන් මේක මම සමහරවිට අහන කෝල්ස් දෙකක් අතර මට ආන්සර් කරනවා. ඒත් එහෙමද කියලා. සමහරට සොෆ්ට්. ඒ කියන්නේ හේත් වහිනවනේ කියන්නේ. බලමු. Yes, so these signs of placental separation are not, I mean, they are just signs only. We haven't seen placental separation. So the most important thing is to apply control contraction if the placenta is well contracted. So if the uterus is well contracted, because if you do so, even if the placenta is still attached, inversion won't occur. And my husband in the pattern. නෑ දඹුල්ල පැත්තට කොහිනවද කියලා. කෝල් එකක් ගන්න කියලා. ඕනේ හදිස්සියක් නෑ මොකද අපි හිත සීගිරි යන්න ප්ලෑන් කරලා. දැන් බලන්න මාස 3කට පස්සේ යන්න වෙන්නේ කොහෙවත් මෙහෙම වැස්ස තිබ්බොත් ගිහලා වැඩක් නෑ. පොඩ්ඩක් අහලා බලන්න. පස්සේ කෝල් එකක් දෙන්න කියන කණේ හදිස්සියක් නෑ. හරි. Okay, thank you දර්ශනී. Women who had a normal vaginal delivery develops postpartum hemorrhage. The third stage was managed actively and placental membranes were expelled completely soon after delivery of the baby. Intravenous access is obtained and resuscitation is commenced. What is the most important next step in determining the cause of hemorrhage? So when there's, I put this also just to revise PPH with you all. When there's PPH, what do we do? What's the first step? First step is in resuscitation. And the first step in resuscitation is to obtain intravenous access and start IV fluids, and blood is available, you give the blood. So that's the first step in resuscitation briefly. Then the next step in the management is, the first step in the management is resuscitation. Resuscitation alone won't be enough because we have to stop the bleeding. So next step in the management is to determine the cause of hemorrhage. So first of all, the commonest cause of postpartum hemorrhage is retained placenta or retained placental tissue. So the first thing in determining the cause of hemorrhage, you have to inquire whether the placenta has been removed, and if the placenta has been expelled. If the placenta is expelled, you have to inspect the placenta and membrane to see whether they are complete. But in this question, that has been done. Now, if that was not done, if they said a woman who had a normal vaginal delivery with postpartum hemorrhage, soon after delivery of the baby, intravenous access is obtained and resuscitation is commenced. What is the most important next step in determining the cause of the hemorrhage? Then it should be to inquire whether or to determine whether the placenta and membranes have been expelled completely. That's the first step in determining the cause of hemorrhage. But in this question, they say that was done. Then what is the next step in determining the cause of hemorrhage? So if it is not retained placenta, then there are another three broad groups of postpartum hemorrhage. Even if the placenta is not retained, still there can be atonic postpartum hemorrhage. So we have to find out whether it's atonic, traumatic, or whether it's due to a coagulopathy. So here nothing is mentioned about a coagulopathy. Right? So they are actually wanting to know, when you read this question, they haven't told whether there's a risk of coagulopathy or anything. They're just forgotten about the coagulopathy. So if you take the four broad categories of postpartum hemorrhage, it is tissue is excluded, tone, trauma, and coagulopathy. Now there are no mention about coagulopathy in the responses or in the question. So what they want to know is tone or trauma. When they say, I mean, when you read the question, you will understand. So we'll see the response. Explore the uterus for retained placenta. They are told is complete no. So that is nonsense. They say it is placenta and membranes expelled completely. Then you don't have to explore the uterus or retained placental tissue. Inspect the genital tract for tears. Right, that should be done if it's a traumatic hemorrhage. Perform a full blood count and coagulation profile. Right, that should be done as a baseline, but that doesn't show us the cause of hemorrhage. So the next step is to perform an abdominal examination to determine the consistency of the uterus. If the uterus is hard and persistently hard, it is a traumatic postpartum hemorrhage. Then we should inspect the genital tract for tears. But if the uterus is relaxed or relaxes in between contractions, it's atonic postpartum hemorrhage, and then we should give drugs to, then we should find methods of getting the uterus to contract. Perform an ultrasound scan to explore retained placental tissue. A and E both are not necessary because they say, question says, placenta and membranes are expelled completely. Once the question says that, this is another thing that I wanted to draw your attention. For undergraduate questions, there's nothing in between the lines. So if they say it is expelled completely, it is complete. There's no need to do further exploration. Mm. So since they have told the placenta and membranes to expel completely, you have to trust that. You cannot, there's nothing to read in between lines. Therefore, A and E are totally useless. Right? B, you do it only if the uterus is hard. If the uterus is soft, then what you do is you give drugs. The first step in the management of atonic postpartum hemorrhage is to give oxytocin drugs. What do we give? First drug that we give is oxytocin 10 units. The 5 units IV, repeat. You can repeat it twice, but up to 10 units. Then start oxytocin drip with 40 units of oxytocin in 500 milliliters of normal saline. Run it at 125 milliliters per hour. Then also you can do ergometrin, 0.5 milligrams IV. Repeat another dose. Insert misoprostol into the rectum. If carboprost is available, we can give carboprost. And also tranexamic acid, 1000 milligrams IV can be given. At the same time, you have to massage the uterus. If this doesn't work, then it's balloon tamponade. If that also doesn't work, you take to the theater and do like brace sutures. And finally, internal iliac, uterine artery and internal iliac ligation finally is straightened. That's the order of events. So just go and read postpartum hemorrhage. This is how my first is resuscitation. Next is determine the cause. Inquire whether placenta and membranes are delivered. If they are delivered, and complete, inspect to see whether they are complete. If they are complete, next palpate the uterus to determine the consistency. If it's hard, inspect the genital tract for tears. If it is not contracted, then first give oxytocin drugs. You have to know the doses of oxytocin drugs together with massaging the uterus. If that doesn't work, it's balloon tamponade. If that also doesn't work, it's application of brace sutures. If that also doesn't work, selective devascularization with uterine arteries, and then internal iliac arteries, and finally it is hysterectomy. So that's they can ask you at any step. They can say oxytocin drugs are given, but it's the next step in the management. Then it becomes balloon tamponade, or they might come up to balloon tamponade and ask, what is the next step in the management? So whenever they ask what is the next step in the management of anything, you have to read the question very carefully and see where they have ended. Any questions from these two? Anything you want to ask? Each question that I have given, there is a reason to give it. This is not only a paper, this is also for revision. Any questions? If no questions, we'll go ahead. A primary para with a brief presentation, second stage of labor. Recurrent type 2 decelerations are found on the cardiotopogram. She's getting 3 uterine contractions per 10 minutes. Breech is felt at the level of ischial spines. The pelvis is adequate. The estimated fetal weight is 3 kilograms. What is the most appropriate management? So what they are saying, this is quite enough to diagnose fetal distress. And remember, in breech presentation, even if we want fetal scalp blood sampling cannot be done. So in breech presentation, we depend on the CTG. Keep that in mind to determine whether there's fetal distress. So she has got fetal distress in the second stage of labor, right? Pelvis is adequate, breech is at the level of the ischial spines, estimated fetal weight is average. What can you do? Now, I have told you repeatedly, first or second stage problems in breech presentation, the only option is cesarean section. There's no other option. If they said she has been a second stage for 2 hours and the breech is at the level of the ischial spines or 1 centimeter below the spines, and the contractions are 2 per 10 minutes, still we don't open. Because prolonged second stage in a breech is an indication for section. Prolonged fetal distress in the second stage in a breech is an indication for a section, because there's nothing else that we can do. Breech extraction is totally contraindicated. In breech presentation. In singleton breech extraction is never done. So the only possibility for a second stage problem in a breech presentation at the prolonged second stage of fetal distress is to perform a cesarean section. We'll see the response. What is the most appropriate management? Fetal blood sampling from the buttocks is never done. Change the maternal position, improve hydration with intravenous fluids, right? That can be done, but that is only the first step in the management. That might or might not work. It's not that they said what is the first stage in the first step in the management, that may be correct. But they are asking, remember, they are asking what is the most appropriate management, not the first step in the management. If they said first step in the management, that may be the answer. Change the maternal position and improve hydration with intravenous. Not only that, we have to be very sure that there's no cord prolapse. Because breech, even in the second stage, cord prolapse can occur. Encourage the patient to bear down to expedite delivery. We can't do that, because unless the woman is already bearing down and delivery is imminent, we can do that. But breech is just at the level of the spine, so she's in the passive second stage most probably, unless if they said she's in the active second stage and breech is at +2 level, then we might be able to bear down to expedite delivery. But here we cannot do that. Lower segment cesarean section is the only option. Breech extraction is never done. Any questions? Remember, footling breech cannot go for vaginal delivery. Why? Because foot is a very small presenting part. It can, cord prolapse is very likely to occur because there's room for cord to float down when the membranes rupture. And also, foot is a very poor stimulator of the cervix. Therefore, prolonged labor can occur. And also the worst thing, another bad thing is the foot can come out through a partially dilated cervix, press on the pelvic floor, stimulate premature bearing down efforts. And if the woman bears down prematurely before full dilatation of the cervix, the breech will come down because it's soft, but the head will get stuck. So because of these reasons, foot limb breech is an indication for section. I had told you all earlier, foot limb breech can only be diagnosed after the onset of labor when the cervix is about 5 centimeters dilated. What is footling breach? Footling breach is where the foot is the presenting part. Foot is below the buttocks. Foot is at the level of the internal also. That is what you call a footling breach. The other contraindication for vaginal delivery, I'm talking about a patient who has been selected for vaginal delivery. There are so many other contraindications of vaginal delivery. Go and read the book. But a woman who has been selected for vaginal delivery, if during labor we find it's a footling breach, then we have to do a section immediately. Then right at the onset of labor, we should do ultrasound scan to exclude hyperextension of the neck. Hyperextension of the neck at the onset of labor is an indication for cesarean section in a woman hitherto. Hitherto we have decided to do a vaginal delivery. If it's a footling breach or a hyperextension of the neck is detected at the onset of labor or during labor, is an indication for cesarean section. Then I'll remind you there are certain other presentations that you can diagnose only during labor at about 5 centimeter dilatation. One is brow presentation, other one is face presentation. Then occipito-posterior position also can be confirmed only after the onset of labor at about 5 centimeter dilatation. All these are confirmed by doing a vaginal examination. Any other questions? Any questions? Any questions? ළමයි ඉන්නවද දන්නේ සත්‍යකුත් නැහැ. මේක දාලා නිකන් ගිහිල්ලා වෙන්න පුළුවන් ලොගින් වෙලා බුද්ධියද දන්නේ නැත්නම් ලොගින් වෙලා ට්‍රිප් එකක් ගිහිල්ලාද දන්නේ
Here.
සද්ද නැහැනේ මම විතරක් කතා කරනවා.
Madam, we are here. I have one question, madam.
Yeah.
In breech delivery, how and when are we going to diagnose hyperextended neck?
We can diagnose just before the onset of labor. Ideally, if we decide to send a woman for normal delivery in a breech, at the onset of labor, like we should exclude hyperextension of the neck. Hello, Mr. Hemanta. Dambullet මේ වගේද? දැන් ආවෝ වැටලපි 12 විතරනේ කප් වෙනකොට මට කියනවාද මොකද වෙන්නේ කියලා. නෑ අපි හිත බුක් කරා වෝටර් ගාඩන් එක. මම තාම සල්ලි ගෙව්වේ නෑ. ඔය වාසේ නේ අර සැලේස්නේ බුක් කරා. ඉතින් මේ දවස්වල ලාභයිත් නේ. ඉතින් යන්නත් ආසයි ඉතින් මේ වගේ දැන් මේ නුවර වගේ තත්ත්වයක් තියෙනවා නම් ගිහලා වැඩක්ම නෑනේ. මොකද? චුට්ටක් වැස්ස පැයක් දෙකක් විතර නේ. අපට අනේ 12ක වෙනකොට කියනවාද මිස්ටර් මන්ට ඒකත් කොහමද කියලා. මං තාම සල්ලි ගෙව්වේ නෑ. මිනිස්සු 50% ඉල්ලනවා කියන්නේ ඉස්සෙල්ලා. මොන 50% මිනිස්සු එක්කත් නෑ ඔය. මම පස්සේ මට එකට දෙකට කියන්න බලමු. අවස් වෙනකොට බලමු thank you Mr. Hemanta. Depress වෙලා ඉන්නේ දැන් ගෙදරට වෙලා ඉන්නකොට depress නේ. හරි thank you Mr. Hemanta. මම දෙකට විතරයි call එකක් දෙන්න. හරි thank you. Yeah, so before we actually allow vaginal delivery, we have to be very sure that there's no hyperextension of the neck. But footling which can be diagnosed only after the onset of labor. I will do a few more questions, right? On malpresentations. Now, you can see the screen again, no? What about, we'll take this question. A primary para asking the these are from the book, you all can refer it. Second stage of labor for 3 hours, head is fully engaged. On vaginal examination, a soft presenting part is felt 1 centimeter below the ischial spines. Eyes, nose, and mouth are felt. That means it's a face presentation. Chin is anterior, membranes absent, pelvis is adequate. She's getting 3 uterine contractions from 10 minutes. Fetal heart is 140 beats per minute. She has been in the second stage for 3 hours. Therefore, it is now 100, which has exceeded the time, so we have to deliver. So I have told you a mental anterior face presentation can be delivered by applying obstetric forceps. So we apply Simpson's forceps because it is only 1 centimeter below the ischial spines. We cannot apply Wrigley's forceps. We cannot apply oxytocin and observe, even though the contractions are little inadequate. She should be getting 4 to 5 contractions per 10 minutes in the second stage, but only 3, but she has exceeded the time limit. Therefore, we cannot observe for 1 hour. There's no need to perform a section because all criteria for forceps delivery are satisfied. Presentation and position are suitable, cervix is fully dilated, pelvis is adequate, and the presenting part is 1 centimeter below the ischial spines. So the 4 major criteria are satisfied, and we can apply obstetric forceps. If they say chin is posterior, then we have to go for a section. That means a mentor-posterior face presentation has been missed. Now, what is the management of a transverse line? Even if it comes a term before the onset of labor, first step is external cephalic version if there are no contraindications. If that fails, of course, we'll have to go for a section. There's no other way of delivering a transverse line. If it fails, you have to go for a section. Even now, if they come in labor with a transverse line, even if the fetus is dead, we have to go for a section.
Madam,
Yeah.
in the transverse line, until what time we can wait, madam?
We can do a external cephalic version up to 40 weeks from undergraduate point of view. There's something called stabilizing induction where we can do a version even in the early stages of labor, but I don't think you all should have to know that. So as far as undergraduates are concerned, we can do external cephalic version at any time before the onset of labor. If that fails, we have to go for a section. Hurry them. So,
Okay.
like any other prepare one, we attempt external cephalic version in a primary at 36 weeks, in a multi at 38 weeks. We start external cephalic version. If it fails, of course, then we have to do a section. What do we do if the external version succeeds but reverts back to the transverse line? Then, of course, still it is risky. We can attempt it again, but better to go for a section. Okay, tava intricacies තියෙනවා, but I don't want to confuse you all with it. because you'll be only given a very straightforward question. Now, there are certain contraindications of breech delivery. Now, being a prime is also a relative contraindication. So, if at any time a prime comes with a breech presentation, again, first step is external cephalic version. If it fails, we go for a section because the lower limit is 36 for a primary, 37 for a multi, but there's no upper limit. So if she comes at any time, if previously external cephalic version has failed, then we have to plan for a section at 38 weeks or 39 weeks. But if previous external cephalic version has not been done, and she comes at term, then we can at 38, 39 or 40, we can attempt external cephalic version. If it fails, only we do a section. But external cephalic version done at 36 weeks fail, then we have to decide to do a section by 39 weeks. මොකද exam එකට නම් 39 weeks, වාට්ටුවේ නම් 38 weeks. The guidelines say elective section should be done at 39 weeks to ensure lung maturity.
Madam, one question regarding transverse lies and
Yeah.
dead fetus. Madam, if the woman presents before having labor pains with the dead fetus lying in transverse lie, do we still attempt ECV?
Do we still attempt?
Do we still, Madam, if the patient
ECV?
presents with
No.
dead
No,
fetus,
because some macerated fetuses, we cannot attempt the ECV because the life will be very reduced. Only live fetuses we attempt ECV. We cannot attempt ECV in dead fetuses. That's a very good question. මමත් හිතුවේ නෑ ඔයාලා. Now see this question, we will really get carried away. A 28-year-old second para with a breech presentation is in labor. Her previous pregnancy had ended in a vaginal delivery after 6 hours in labor. Birth weight was 3.3 kilos. Right, so previous delivery was easy. Her previous birth weight was 3.3. Now she has come in labor. She's getting 2 uterine contractions per 10 minutes. Cervical dilatation is 5 centimeter dilatation, 2 contractions are enough. Foot is felt below the cervical loss. Head felt below the cervical loss or below at the level of the cervical loss. Below the pelvis is adequate. Estimated fetal weight is 2.8. Then everything is satisfied for a vaginal delivery. She's a second para with a previous easy vaginal delivery. She's in spontaneous onset of labor. Pelvis is adequate. Estimated fetal weight is less than the previous baby. So you get carried away that this can go for a vaginal delivery if you didn't know that foot-wing breech is a contraindication for vaginal delivery. The next question is the same question, same thing. Membranes are intact at 5 centimeters. Everything is normal. Breech is felt Membranes are intact, breech is 1 centimeter above the ischial spines, cord is not felt, pelvis is adequate, estimated fetal weight is less than the previous baby, fetal heart rate is normal, pregnancy is otherwise uncomplicated. So this woman can be allowed to go through a vaginal delivery because there's no abnormality at all. She's a second para with a previous easy vaginal delivery. This pregnancy, this labor seems to be totally uncomplicated. Estimated fetal weight is also less than the previous baby. So, and the pregnancy is also uncomplicated. Labor also seems to be uncomplicated up to now. So the best management option is allow labor to progress for 4 hours without interference. Epidural analgesia, of course, should be commenced. Amniotomy should not be commenced because in a breech, amniotomy is done only at a later stage when the breech is well descended and well applied to the cervix. You only do amniotomy. You should not be in a hurry to do an amniotomy because of the risk of cord prolapse. Oxytocin is not commenced. If after 4 hours progress is not enough, then if there's lack of progress, we'll have to go for a section. Right. So I just brought some things to your important things to your notice. Any questions? We'll go back to the previous one. Any questions? Woman with diabetes mellitus attends the antenatal clinic at 20 weeks. Fasting blood sugar is 5 millimole, that's normal. 2-hour postprandial values are also normal. Preprandial blood sugar between lunch and dinner are high. She's on 3 pre-meal doses of soluble insulin. What is the best management option? At 3 doses of metformin may not work. 2 doses of mixed-dose insulin. This can be done, but what this shows is that she's eating something in between meals. The first step in the management is to advise her to avoid taking snacks between meals. If they said in the question she's not taking anything in between meals, then of course we might have to add a dose of mixed-dose insulin in the morning as a long-acting insulin to prevent the preprandial blood sugar elevation. But the most important thing is, first step is to advise her to avoid taking snacks between meals because the elevation of preprandial blood sugar indicates that she's most probably taking snacks in between meals. Advising her to reduce carbohydrate intake at main meals is not the solution because the postprandial blood sugars are normal. Increasing the dose of soluble insulin also won't work because postprandial blood sugars are normal. Woman is admitted to the antenatal ward at 35 weeks. Her blood pressure is sometimes 110 and urine contains albumin. She has a generalized seizure during examination and oropharyngeal airway is inserted. Which of the following should be the most appropriate next step? Now, what is the first step if someone fits? Is to clear the airway. That has been done. Then the next step, now we can diagnose that this is eclampsia. Because blood pressure is 170 by 110, she is pregnant and urine contains albumin. So this is eclampsia. So what is the next step in the management is to prevent further fits. For that, what do we give? We have to give a 4-gram bolus of magnesium sulfate by slow intravenous injection. And then, of course, we commence on a magnesium sulfate infusion at the rate of 1 gram per hour. So that's the next step. Giving hydralazine is the third step to reduce the blood pressure. Then the final step is admit to the ICU, and then the what is the most appropriate definitive treatment if they ask, it is to do a section and delivery. So first step is maintain the airway. Next step is give magnesium sulfate, reduce the blood pressure, admit to the send certain investigations, meaning the coagulation profile, liver function test, full blood count, and blood grouping and DT. And because we need to deliver, and then arrange for a cesarean section as soon as possible. These are the 5 main steps in 6 main steps. Airway, magnesium sulfate, reduction of the blood pressure, admit to the ICU, send certain reduction of blood pressure, send certain investigations, admit to the ICU, and arrange for cesarean section as soon as possible in that order. A 24-year-old primary para who is under treatment for tonic-clonic epilepsy for 7 years attends the antenatal clinic. She is on sodium valproate and phenytoin. The disease is poorly controlled. The last stage occurred 1 month ago. What is the first step in the management? ඇත්තටම මේකට හරි උත්තරේ තමයි ඒක මෙතන දීලා නැහැ. Refer to the neurologist to review and readjust the medication. That is the correct management, but it's not given here. So we'll take the other responses. We cannot increase the dose of anti-epileptic drugs throughout the pregnancy, even though hemodilution occurs. Folic acid has to be commenced. Monitor the drug levels to determine the optimum doses of drugs won't work. A and C both won't work because she's on those things are not done. We don't increase the dose of even sodium valproate aside. We don't increase the dose of anti-epileptic drugs throughout the pregnancy, and we don't monitor drug levels. Perform an EEG to exclude an intracerebral lesion. That is not necessary because it's a diagnosed patient on epilepsy. That would have been done at the time of diagnosis. Therefore, performing an EEG is not essential. Readjust medication. මෙතන තිබෙන answer එක තමයි readjust medication and replace sodium valproate with carbamazepine. Or we could add all readjust. That is the most important thing. Even what is the best anti-epileptic drugs during pregnancy are carbamazepine and lamotrigine. Rather than sodium valproate and phenytoin, if they said readjust the medication and replace it, carbamazepine and lamotrigine also have been correct, but there's no such response. So therefore, maintain a response. Best response is replace sodium valproate with carbamazepine. So think of the responses that are there also, and choose the best response from the responses that are there. The best treatment option may not be there in the responses, but you have to select the best from what is given in the responses. Any questions up to there?
Madam, I have a question.
Yeah, ask.
When the fetus is lying in the transverse position, when doing a ECV compared to a breech presentation, is there an increased risk of having a placental abruption-like complication?
No, risks are less because you have to bring the head down only through a quarter circle. Head is at the level of the umbilicus. No? In a transverse line, head is at the level of the umbilicus on one side of the uterus. Breech is at the level of the umbilicus on the other side of the uterus. And the presentation is shoulder, and that is also very high. So that is why the moment and also the membranes are poorly supported, because there's no presenting part in the lower segment close to the internal os. Presenting part is the shoulder, and that is also very high. So the membranes remain unsupported. When the membranes have the greatest risk of transverse lies, when the membrane, there can be pre-labor rupture of membranes, because membranes are poorly supported. And when the membranes rupture, the cord and the hand both will come down, because umbilicus is very close to the almost in line with the cervix. Hand is also there. Both will come down. So that is one of the greatest risks of transverse. The other risk is labor cannot do it. Labor will definitely get obstructed in an undetected transverse. So to answer your question, it has to be brought down only by quarter of a circle. Therefore, the complications are very much less than in a breech percentage. Harita, did I answer your question?
Yes, madam. Thank you.
Any other questions? මං කියපු question එකක් තියෙනවා මෙතන. Woman is admitted at 30 weeks with history of having a generalized chronic seizure. Her blood pressure මම ඔක්කොම select කරලා තියෙන්නේ for revision and to all the important ones. Woman is admitted at 30 weeks with history of having a generalized. ඇත්තට මේ ටික හොඳට අහගෙන මේ ටික repeatedly බැලුවොත් that takes you about at least 30% of the way through your exam. Woman is admitted at 30 weeks with history of having a generalized chronic seizure. Her blood pressure is 170/110 and the urine contains albumin. And oropharyngeal valve is inserted and intravenous magnesium sulfate is commenced. Fetal heart sounds are present. There are no uterine contractions. What is the most appropriate management? මෙතන next step කියලා නැහැ. But the important steps have been completed. Diagnosis of eclampsia is obvious. Airway has been settled. Magnesium sulfate has been given. So important first line management has been commenced. තව ටිකක් ඉතුරු වෙලා තියෙනවා. Blood pressure nothing has been given for blood pressure. But they are asking what is the appropriate management. If they ask what is the next step in the management, then the response should be, if such a response is given, should be to reduce the blood pressure. But there's no such response also. So most appropriate management, that response may be there in a question, but that is not the most appropriate management. That is the next step in the management. So right, she has to be admitted to the ICU. There's no doubt about that. That is one of the next steps in the management, but they are asking the most appropriate management. We cannot continue the pregnancy even if it is happened at 24 weeks or 28 weeks. Still, we cannot continue the pregnancy. Once a woman gets fixed, termination is the only option. Otherwise, she continue feeding. The treatment for eclamptic fix is delivery of the baby together with the placenta, because pre-eclampsia is a disease of the placenta. So even if the fetus is dead, if the fetal heart sounds absent care response, but still we have to deliver. But then the delivery, we can try to settle the patient little more before delivery. because when the fetus dies, one thing the fetal aspect is removed. I mean, now we are worried whether we try to save the fetus as much as possible, but if the fetus has already died, then that aspect is not there. And also when the fetus dies, there's some improvement, but improvement is minimal until the placenta is removed. So even if the fetus is dead, we have to deliver by section, right? We cannot, even if it's premature, 28 weeks, not viable, still we have to deliver. Even if it's dead, we have to deliver. So continuing pregnancy till 32 weeks, if the fits are controlled, is out. Labor cannot be induced because she is at 30 weeks. There's no way of inducing labor. Even if she was term, we don't induce labor once they get fixed, because the labor will be prolonged after induction, and fits can occur during labor. Now, if she was the only way that we can allow the vaginal delivery, they say she's about 6-7 centimeters dilated. Then, of course, oxytocin and vaginal delivery is possible. Chandani, one lecture in Adisiyada. 11 පස්සේ So induction of labor is not done. The only way that you can allow vaginal delivery, someone gets fits after onset of labor and they are almost halfway through labor. Then of course we do amniotomy and give oxytocin and move for a very quick delivery. Otherwise we do a section. Perform a cesarean section after administering 2 doses of dexamethasone is not possible. We can't keep her for 12 hours. We perform a cesarean section as soon as possible. Moment the anesthetist there, so the DT has to be done. So what do I mean by soon as possible? We have to give give magnesium sulfate. We have to reduce the blood pressure by giving IV labetalol or hydroxyzine or whatever it is. And then we have to have the investigations. What is it? The coagulation profile, liver function test, full blood count and blood for DT. At least the coagulation profile and the DT should be, and the full blood count should be ready. Liver function tests are not essential. And then we take her for a section. That is what we mean by as soon as possible. We can give 1 dose of dexamethasone, but not anything more. And here the section is done under general anesthesia, not under spinal. Why? For several reasons. One thing is there can be a coagulopathy. Therefore, spinal is best avoided. The other thing is most of the times what they do is they maintain intubation and ventilation for at least 24 hours. To be 100% sure that further fits won't occur. Woman complains of discharge and woman complains of discharge and soreness in the vulvar region at a period of 36 weeks. Examination reveals small discrete tender ulcers in the major, minor, and perineum. She has not had a similar episode previously. So what is this? Tender discrete, small tender discrete ulcers. ඔකට shallow කියලා දැම්මනම් හොඳයි in the vulval area. So what is it? It is definitely herpes. So according to this question, it seems to be a primary episode, but we can't be sure. So now the first thing is to find out whether it's a primary or secondary episode, because it is because immediate because it is a primary episode, then the first step is to find out whether it's a primary or secondary episode, because management differs. So how do we do that? So what we do is we first identify the organism and type the organism, because there are two types, HSV1 and HSV2. So we have to find out whether this infection, the organism and the type that is infecting, and then look for antibodies in the serum against the infecting type. So මෙතන තියෙන electron microscopy and viral culture කියලා චුට්ටක් පරණයි මේක. Now what we do is then PCR ඔක්කොටම ඔකටත් අයිනේ. So identify the infecting organism and the type by PCR, and then test for type-specific antibodies in the maternal serum. If the type-specific antibodies are there, it's a secondary episode. If the antibodies are not there, this is a primary infection. The difference is, if it's a primary infection, we have to deliver by cesarean section by 38 weeks before she goes into labor. If it's a secondary episode, we can allow normal delivery. Why is that? In a primary infection, woman has not yet developed antibodies. Therefore, their baby is not immune. If the woman develops antibodies, IgG antibodies, they will cross the placenta and the baby will be immune against the infection. Therefore, if it's a primary infection at 36 weeks or at 34 weeks, there's no time for the mother to develop antibodies, therefore baby won't be immune. If it occurs in the second trimester, then of course, even if it's a primary episode, then we can anticipate that baby will be immune. But since this has occurred at 36 weeks, baby certainly will not be immune, and the baby can acquire the infection if we allow vaginal delivery. In a secondary, if it's a secondary infection, then of course the baby will have antibodies and we can allow vaginal delivery. What we do is, anyway, we give oral acyclovir until delivery. If we are allowing a vaginal delivery, especially from 36 weeks onwards, we give acyclovir to prevent the presence of ulcers at the time of delivery. Any questions with this? I have summarized the whole thing as far as is necessary for undergraduate. Any question? But
Madam,
God said with the perinatal infections, because they certainly give questions and they are given very nicely in the book.
Madam, do we have to wait until 36 weeks for acyclovir? It wasn't very clear.
No, it can be given even the first trimester. If acyclovir is needed for any infection, it can be given at any time during pregnancy. And nothing against. Earlier they said can't give in the first trimester, but now they are saying can be given. Now, what I mean now, if a woman has a secondary episode of herpes, if she gets that episode at 28 weeks, we'll say, and we are diagnosed a secondary episode, and we are going to give her a vaginal delivery, we prefer not to have ulcers at the time of delivery. Therefore, we can start her on acyclovir from 36 weeks onwards. Prevent recurrence of infection. Because this herpes tends to recur on and off. Okay.
Madam,
Yeah.
I have a question, madam. If the patient
Anna,
is diagnosed at the first trimester, if the patient is diagnosed for herpes at the first trimester, how many weeks should we continue for a cyclovir?
no, now remember herpes is not an indication for acyclovir as it is for the treatment of the illness unless if she has severe pain. If she has severe pain, we can give for now the standard dose is 400 milligrams 3 times a day for 5 days. No? So we give that and we stop. Then if we are worried whether she will get a recurrence at the time of delivery, then at 36 weeks we can restart. But acyclovir is given only if she has severe symptoms. The standard dose is 400 milligrams 3 times a day for 5 days. Okay?
Okay, madam. Thank you.
Perinatal infections and කියවන්න නැතුව යන්න එපා පොතේ විතරයි තියෙන්නේ. වෙන කොහෙවත් හරියට දීලා නැහැ. ඕකෙන් එනවාමයි SBA එක. තියරි එකක් දුන්නොත් මොකද කරන්නේ? එක සැරයක් දීලා අන්තිම සෞත්තුවේ ළමයි උත්තර දුන්නා. දැන් ටික කාලයකට තියරි දීලා නැහැ. මේ සැර දෙන්න ඉඩ තියෙනවා. මොකද ඕක ටෙස්ට් වෙන්නේ නැහැ මේකේ. ඔස්ටි එකේ ටෙස්ට් වෙන්නේ නැහැ. ක්ලිනිකල්ස් වල ටෙස්ට් වෙන්නේ නැහැ. එතකොට SB එකේ ටෙස්ට් වෙන්න පුළුවන්. අනිත් එක තමයි මොකද blueprint එක හැදුවම everything should be included in the paper. No? This can certainly be included in the theory paper. Blueprint එක හැදුවම එක්කෝක SBA කියනවා එක්කෝක theory එක කියනවා. ඒකන්ට අත්තරින්න එපා මම හරීම ඒ කියන්නේ දීලා තියෙනවානේ very summarized. අත්තරින්න කිසිම වමනාවකුත් නැහැ. Woman is exposed to chickenpox at a period of 14 weeks. She does not give a history of having had the disease previously. What is the best management option if she does not have antibodies against varicella zoster virus? Now, once a person is exposed to chickenpox, what do? She comes and tells that she is exposed to chicken. First of all, we ask her, first step is to get a definite history of having had chickenpox. If she has a definite history of having had chickenpox, she is immune. You don't have to do anything else. මේ කොරෝනා වගේනේ අනේ අම්මෝ chickenpox නම් ඇදිලා තියෙනවා නම් ඉන්නේ. Most of the people say they cannot remember or they haven't had. So in that case, if they haven't had or there's a doubt, next thing is you do IgG antibodies in the maternal serum. If the IgG is positive, that means woman is immune, you don't have to do anything. If the IgG is negative, for chickenpox, there is a varicella zoster virus immunoglobulin. There is a varicella zoster virus immunoglobulin. So if she does not have antibodies, we do antibodies. If she doesn't have IgG antibodies against varicella zoster, we can administer varicella zoster immunoglobulin. It's effective if you administer it within 10 weeks or within 10 days of exposure. So there's no varicella. There's a varicella zoster vaccine, but it's we cannot administer it because it's a live attenuated vaccine. So vaccine cannot be given. Varicella zoster immunoglobulin as soon as possible after exposure is the answer if she has not had varicella zoster earlier, and also if she doesn't have IgG antibody. termination of pregnancy is not necessary, whatever the reason, because termination of pregnancy is not necessary, because even if she gets varicella, because effects are not very marked. Incidence of fetal varicella syndrome is very low, I think somewhere around 2% or something like that. The incidence. Termination of pregnancy, therefore not indicated, because the incidence of fetal varicella syndrome is low even in the first trimester. Reassure that infection will not cause serious fetal defects. That can be done if she gets chickenpox, but here it's not that is not the appropriate answer, because she has only been exposed. She has not got chickenpox. Therefore, there's a treatment for that. So the best management option is to treat for the exposure, and that is to give varicella zoster immunoglobulin as soon as possible after exposure. So the steps are: inquiry regarding infection. If no infection, check the IgG. If IgG is positive, reassure. If it's negative, give varicella zoster immunoglobulin within 10 days of exposure. And if re-exposure occurs after 3 weeks, you have to give a second dose. If she gets varicella zoster, we can treat with acyclovir, but the incidence is low. It's not an indication for termination. How do you find out? And second and third trimester incidence is very low. How do you find out whether the baby has developed varicella zoster? We do an ultrasound scan 5 weeks after exposure and after 20 weeks. And there are certain defects, skeletal defects and all that. All that is given in the book. At 25-year primary para, who is on part from 24 weeks, is admitted at a period of 36 weeks with a history of dribbling for 2 hours. Viral load is 25 copies per milliliter. What is the most appropriate management? Augment labor immediately. Yes, because she's dribbling and she's 36 weeks. She has HIV, but vaginal delivery is possible because viral load is 25 copies per milliliter. So the most appropriate management is to augment labor immediately. Intramuscular, we don't wait for 24 hours, 36 weeks, therefore we can augment labor immediately. Commence intramuscular corticosteroids, we don't wait. Commence intravenous riluzole and await spontaneous onset of labor, no. Perform a cesarean section immediately, yes, if the viral load was more than 50. Because she's 30, if anyone more than 34 weeks, better to augment labor immediately. Less than 34 weeks, of course, then we have to have MDT and decide whether we are going to augment labor or whether we are going to wait, because her viral load is low. I think after doing the normal labor MCQs, I will do MCQs on perinatal infections. මොකද HIV වලින්ම ගොඩක් තියෙනවා. That we should know. අපි එහෙම කරමු. If the viral load was more than 50, you have to do a cesarean section immediately. So the indications of cesarean section are viral load more than 50, and as the mode of delivery in any woman with HIV, if the viral load is more than 50, we have to do a section. And also, if she has not been on CAR, she has only been on monotherapy, then we have to do a cesarean section. We allow normal delivery only in people who are on CAR who have had repeated viral loads of less than 50 copies per milliliter. Any questions? Going back to the previous question, what if I told you that what if the woman comes with chickenpox in the third trimester, close upon term, we try to delay delivery. But if she comes in labor, what do we do? Then we cannot delay delivery. We allow labor to progress and we give varicella zoster immunoglobulin to the baby soon after delivery. We don't do the vaccine, most probably because baby's immune system is not well formed and it's the live attenuated vaccine. Women with a twin pregnancy complaints are reduced fetal movements at 32 weeks. T sign was present in the ultrasound scan performed at 12 weeks. An ultrasound scan performed after admission shows reversed end-diastolic velocity in the first twin and normal end-diastolic velocity in the second twin and fetal weight discordance. So one twin might die at any moment. Now, presence of a T sign means they are monochorionic twins. Therefore, in a monochorionic twins, a special problem is if the one twin decides to die, the other twin will also die and be compromised. 32 weeks, the PO is quite enough to deliver. Therefore, the appropriate management is to perform a cesarean section immediately after administering one dose of corticosteroids. We can't even wait for 2 doses because if one twin dies, we might lose both twins. 32 is quite survivable outside. Therefore, what we do is we administer corticosteroids 1 dose and deliver them with the hope of at least surviving the better twin. We don't do the doctor's venosus Doppler because 32 is, that's an option. That's an option. Perform a cesarean section with the doctor's venosus Doppler flow studies is abnormal because it's still 32 weeks. And that is also a good option. Right? Because it's 32 weeks. Up to 32 weeks, doctors venosus Doppler. I don't know whether that is also, now when I go through it, I feel that it's also a good option because 32 weeks. ඒ දෙකම ක්‍රොස් රියැක්ට් වෙනවාද කියන එක දැන් මට ඩවුට් එකක් තියෙනවා. මේ දෙකෙන් මොකක්ද කියන්නේ? Both are correct. Perform a cardio topograph twice daily is of no value. Perform a daily umbilical artery Doppler studies and observe for 1 week if the second twin has normal blood flow. No, that doesn't, we cannot observe for 1 week after performing umbilical artery Doppler study because it's reversed. Any moment the baby can die. Only other answer that we can take is because we can do doctor's venosus Doppler studies to further evaluate the fetal blood flow. දෙකම හරිය කියලා මම හිතනවා. But I හිතනවා, but A is more correct because it's 32 and the fetuses are viable. If it was 30 years, certainly yes. C is the answer. But because 32, I feel A is the most correct answer. 30, even 31C may be the correct answer. But because 32, I think A is the correct answer. Any questions? Any questions? Did you all understand or didn't understand at all? There are certain complications which are specific for monochorionic twins. One is twin to twin transfusion, other one is selective growth restriction. Then the other one is if one twin decides to die, other twin will either die or be seriously compromised. So here the basic clinical principle that I use is deliver because one twin is compromised, might die at any moment. That will affect the other twin. And because she's 32 weeks, delivery would be the best option because viability is okay. But of course, you have to have MDT meeting and decide what we can do in such a drastic situation. Best thing is to have an MDT meeting. Now here, a woman who had a normal vaginal delivery 3 days ago, complains all over abdominal pain and offensive vaginal discharge. 39 pulses, 139, and that's what is it called in the Q's opus? Oh, she has severe sepsis. So what are the steps in severe sepsis? First is to resuscitation with IV fluids. Next step is to send the blood and the relevant secretions from culture and ABST. Third is to use broad spectrum antibiotics. Fourth is to do infection screening as a parameter. Fifth is to do an ultrasound scan. If we suspect the focus is in the pelvis, do ultrasound scan to exclude pelvic abscess, interperitoneal pus. And the sixth is to admit to ICU for monitoring. So the first step is resuscitation. There's a resuscitation is done. Next step is to send blood and hyperjanus of culture and ABST. And then we start broad spectrum antibiotics. Then we do the infection screen as a baseline. Then we do an ultrasound scan to see whether there is any collection of pus in the peritoneal cat. If there's no other focus outside, and we admit to the ICU. Because according to the Q score, she has a score of 3 and she has serious sepsis. Any questions? ළමයි එන්නේ නඩු වෙනවා අපි නවත්තමුද එහෙනම් 38ක් හිටිය දැන් ඉන්නේ 34යි. තව questions දෙකක් කළා මම නවත්තන මටයි ඕනකම තියෙන ඔයගොල්ලන්ට නම් කිසිම ඕනකමක් නැහැ. තව questions කීයක් තියෙනවද? ගයිනි ඒවා ටික එහෙමම තියෙනවා. A primary para is admitted at a period of amenorrhea of 34 weeks. Fetal weight estimated for the ultrasound scan is less than the 10 centimeter gestational age. Amniotic fluid index is 4. Umbilical artery and diastolic flow is absent. What is the best management option? Now she's 34 weeks, there's growth restriction, and umbilical artery and diastolic flow is absent. After 34 weeks, these are indications of delivery. Therefore, we have to deliver. But only thing, because the umbilical artery end-diastole is absent and not reversed, we can perform a cesarean section after giving steroids. If the umbilical artery end-diastole flow was reversed, then of course we perform a cesarean section after giving one dose of steroids. Because it is only absent, we can do after, we can assess. Of course, all these things need MDT meeting. After MDT assessment, we can perform a cesarean section after giving a course of steroids. දැන් මේ එකකවත් මම MDT කතාවක් දාලා නැහැ. මේ පොත පොඩ්ඩක් second edition එකක් දැනට වැඩිය පරණයි. දැන් නම් හැම දෙයකම කෝකට කයිලේ තමයි MDT. දැන් මේක ඇහුවනම් what is the first step in the management? Then if there was a response saying arrange MDT meeting to determine the optimal time and mode of delivery. That is the next step in the management. ඊට අර ක්ලින්ස් එකෙත් එහෙම තමයි. Then MDT, when I'm doing the MCQs, I will always consider the MDT. What is the first step in the management? And if there's such a response, then arrange an MDT meeting to decide on the time and mode of delivery. That would be the best option. And kisi දෙයක් කරන්න බෑ MDT. MDT තමයි first step ඕකට කයිද වෙලා තියෙන්නේ. Cardiotocography is of no value. There's something called computerized cardiotocography. Therefore, there are certain parameters which indicate delivery. Perform LSCs. If the doctor's venosus Doppler is reversed, we don't do doctor's venosus Doppler at 34 weeks. Perform MCA Doppler studies. No, MCA Doppler is done after 34 weeks. Only if the umbilical artery Doppler is normal. If the umbilical artery Doppler is abnormal, we don't cross-check with MCA Doppler. We cross-check with MCA Doppler only if the umbilical artery Doppler is abnormal. Perform umbilical artery Doppler flow studies daily. There's actually, that is also an option. We can say another option would be, if they said perform umbilical artery Doppler studies daily and deliver if it is reversed. But according to the guidelines, umbilical artery Doppler flow being absent at 34 weeks is an indication for delivery. And so therefore, I think by the principles of the guideline, we should deliver rather than doing the Doppler flow studies daily. ළමයි එන්නේ නඩු වෙනවා මම ඒක හන්ද නවත්තනවා වැඩිම වුණොත් කොහෙද මම ඉන්නේ ඔතන එකයි තියෙන ඔප්ෂන් එක ඉවර කරලා නවත්තනවා මටත් හොඳයි කලින් මම 11 කාලේ විතරක් කරා විතර වෙනකම් කරන්න බලාපොරොත්තු තිබ්බේ එන්නේ නඩු වෙනවා හන්ද නවත්තනවා. A 25-year-old woman is admitted at 38 weeks. The fetus is in the cephalic presentation. The head is engaged. The amniotic fluid index is 10, and the umbilical artery end-diastolic flow and the cardiotocograph are normal. The estimated fetal weight is less than the 10th centile. She has no other pregnancy complications. Cervix is 50% effaced and the ovaries dilated to 1 centimeter. She has come at 38 weeks. There is fetal growth restriction, therefore delivery is indicated by the basic clinical principles. After 37 weeks, we should deliver if there is any indication of growth restriction. So therefore, we have to deliver, and there's no indication for section because no other pregnancy complications called and the umbilical artery and diastolic velocity are normal. I mean, if we like, we can test recheck with the MCA. ඒක තියෙනවා මෙතන. Next step in the management is that is the answer. Insert vaginal prostaglandin to induce labor. The next step in the management is, of course, to perform middle cerebral artery Doppler studies. If that is also normal and the cerebral placental ratio is more than 5, still we should deliver because it's 38 weeks. If MCR is also normal, then we should insert vaginal prostaglandin to induce labor. Methana tibbana, what is the most appropriate management? And then, of course, it becomes to insert vaginal prostaglandin to induce labor because the umbilical artery Doppler is normal. Not much value when doing the middle cerebral artery Doppler, but since they are the next step in the management, middle cerebral artery Doppler would be the correct answer because we cross-check on the umbilical artery Doppler. If middle cerebral artery Doppler is also normal, we can easily go for a vaginal delivery after induction of labor. Now, any questions? මේ ඔක්කොම බලන ගමන් ආපහු read the relevant chapters also. අපි මෙච්චරක් උගන්න ඒත් අපිව අන්තිම තැනට පල්ලෙහාට බස් කරනවා නම් හැම ඩිපාර්ට්මන්ට් එකේම හොඳට උගන්වනවා. ඒත් අපිව අන්තිම තැනට බස් කරන්නේ මොකද ඔයගොල්ලෝ උගන්වන තැන් වලට එන්නේ නැහැ 32කට බහැලා. උගන්වන තැන් වලට එන්නේ නැහැ. ඉගෙන ගන්න ඕනේ මොනවා කරන්නද? පටන් ගන්නකොටත් හරි වෙලාවට පටන් ගන්න බැරි වුණා හිටියේ නෑ. Any questions?
Madam, I have a question.
Yeah.
After 35 weeks, madam, the value is that the value of the MCA declines, or is it the same?
After 34 weeks only we use the MCA Doppler. Up to 38 we can use. Check the cerebroplacental ratio, but only if the umbilical artery Doppler is normal. If it is abnormal, that is an indication to deliver rather than if the umbilical artery Doppler is absent or reversed, it's an indication for delivery rather than cross-checking with MCA Doppler. The most important thing is umbilical artery Doppler. MCA Doppler is second line. Any other questions? Is it okay? වාගේ හිතේ තිබ්බේ ඒකද මම දන්නේ.
Yes, madam. It is okay.
Any other questions? ඔයාලා මට කොච්චර ඕන නැද්ද කියලා පේනවා. එක්කෙනා යනකොට මොකද මේක අහන් ඉන්න. ඇඳේ ඉඳන් අහන් ඉන්න පුළුවන්. ගමනක් යනවා නම් ඒත් මේ ඔයගලන්ට ඩේටා තියෙනවා අහන් ඉන්න පුළුවන්. මේ මොකුත් එපා කියලා නිවල යනවා. හොඳයි. එච්චරවත් ඕනේ.
Madam, excuse me. I am a bit confused regarding the 21st question, the last one you discussed.
Yeah.
If we perform middle cerebral artery Doppler and it's normal, are we going to do the labor, induce the labor?
After 37 to 38 weeks, if we say there's growth restriction, we have to deliver. We can deliver vaginally. If the MCA is also normal, Doppler umbilical artery Doppler is also negative delay, but by basic clinical principles, we don't allow a growth restricted fetus to proceed after 38 weeks. Still, we have to leave. හරිද? I mean, term වලට ගෙනියන්න පුළුවන් under exceptional circumstances. Just give me a minute. Since all are asking, I'll just check in the RCOG guideline. Just wait for a minute, right? In 2 or 3 minutes, I can get at the optimal method. And you all can hear me.
Yes, madam. Yes,
The
madam.
optimal method and frequency of fetal surveillance in SGA. The use of umbilical artery Doppler is the most important one. Umbilical artery Doppler should be the primary surveillance tool in SGA fetus. When the umbilical artery flow indices are normal, it's reasonable to repeat surveillance every 14 days. More frequent Doppler surveillance may be appropriate in a severely SGA fetus. When the umbilical artery Doppler flow indices are abnormal and delivery is not indicated, repeat surveillance twice weekly if the end-diastolic velocity is present, and daily with fetuses with absent or reverse end-diastolic velocities. So if the umbilical artery end-diastolic velocity is reduced, we should, if delivery is one the option, but if delivery is not being done, we have to do the surveillance twice weekly if it is reduced. If it's absent or reversed, we have to do surveillance daily. CTG should not be used as the only form of surveillance in SGA fetuses. If CTG is used, it should be based on the computerized analysis. Biophysical profile should not be used for fetal surveillance because biophysical mechanism in preterm care, but it's not used in because biophysical profile becomes abnormal only just before death. So it's not used in a way of monitoring. But keep that in mind. That can become in a SBS. So CTG is not used as a method of monitoring. Amniotic fluid volume is not used as a method of monitoring. BPP is not used as a method of monitoring. In preterm SGA fetus, middle cerebral artery has limited accuracy for acidemia and adverse outcomes and should not be used to time delivery. In the term SGA fetus with normal umbilical artery Doppler and abnormal middle cerebral artery Doppler has moderate prediction value for acidosis at birth and should be used to time delivery. Okay. So if the umbilical artery is normal and the MCA Doppler is abnormal in the term fetus, that is, we talk about term is after 34 weeks, that's an indication, that may be an indication to deliver, depending on the abnormal to the middle cerebral artery Doppler. Usually we take the cerebroplacental ratio. It should be less than the 5th center. Ductus venosus Doppler has moderate predictive value for acidemia. Of course, make it clear and preterm. Ductus venosus Doppler screws are surveillance in the preterm SGA fetus with abnormal umbilical artery Doppler uses after before 34 weeks. Optimal gestation to deliver the SGA fetus. Preterm SGA fetus, with umbilical artery absent or reversed end-diastolic velocity before 32 weeks of gestation. Delivery is recommended when ductus venosus Doppler becomes abnormal, or yes, when the ductus venosus Doppler becomes abnormal. Even when ductus venosus Doppler is normal, delivery is recommended by 32 weeks of gestation and should be considered between 32 to 32 weeks of gestation. එතකොට අර twins එකට delivery is the indication, because they say even when the ductus venosus, in other words, they are telling ductus venosus Doppler is can be ignored at 32 weeks. Even if it is normal, it should be delivered. ඒකට අරක මම මේක තමයි මේ principle එක තමයි twins question එකට අරන් තියෙන්නේ. So rather than doing ductus venosus Doppler, because the PO is 32, better to deliver. If MCA Doppler is abnormal, delivery should be recommended no later than 37 weeks of gestation. In SGA fetus detected after 32 weeks of gestation with umbilical artery Doppler, a senior obstetrician should be involved to determine the timing and mode of birth. Delivery should be offered at 37 weeks of gestation. So in SGA fetus, always with normal umbilical artery Doppler, normal MCA Doppler, still delivery should be offered at 37 weeks of gestation. How should it be delivered? If there's umbilical artery Doppler is absent or reverse, it should be delivered by section. Normal umbilical artery Doppler, or if it's only just reduced, induction can be done. So if according to the RCOG guideline, cesarean section is indicated only if the umbilical artery Doppler is absent or reversed. If it is reduced or only normal vaginal delivery, the induction of labor is possible. හරිද මම මේ ටික ඔයගලන්ට එවන්න. මේ ටික ඔයගොල්ලෝ අහන ප්‍රශ්න ඔක්කොටම උත්තර හොඳට තියෙනවා. හරිද? Any questions now?
Madam, in case of an abnormal umbilical artery, is the surveillance done using middle cerebral artery or ductus
No,
venosus, or just
normal. The middle cerebral artery surveillance is done only in the presence of a normal umbilical artery Doppler. It's an added precaution. Can I put it that way? Added precaution to make sure that everything is normal. But if the umbilical artery Doppler shows any abnormality, middle cerebral artery Doppler is of no value. That is definite. There's no two words for that. කොහේ කොහොම තිබ්බත් ඒක තමයි ඇත්ත. Hello. එනවා 12:45. අවසන්. වැඩි ඉරිදා නේද? කවුරුත් වැඩ කරන අය සඳුදා. Right, is that okay? But keep in mind, MCA is used only to cross check. If the umbilical artery is normal. Hello. අනේ මම දන්නේ ලෙඩු ඉන්න ගානට ඉන්නවා.
So, madam, in case of normal umbilical artery, we are doing the surveillance using middle cerebral artery. Is that the meaning of it?
Yes. Added surveillance. Not
Okay.
that it is essential, even that is not essential. But if we can, it's an added precaution. Right? It's an added precaution to make sure that everything is normal. If it is abnormal, even though the umbilical artery Doppler is normal, the middle cerebral artery is abnormal, we should deliver by 37 weeks. Hello. අනේ මට උන්නෝක දීලා දාන මට ෂෙඩියුල් එක හරියට මතක නැහැ. එක මහා යොතන මේ මම හිතන්නේ රංජිනී යොතන තිබ්බා. හරිද ජනිත්? If
Yes,
with the
ma'am.
normal umbilical artery, the middle cerebral artery Doppler is abnormal, then we have to deliver by 37 weeks. ජනිත් හරිද ඔයාලට තේරුණාද?
ඔව් මම තේරුණා.
මම අර ටික ඔක්කොම එවන්නම් copy කරලා එක හරි ලේසි just to copy and paste and send.
හරි.
හරි ළමයි නෑනේ කන්න 31කට ගිලා නේ ඇත්තටම. අනේ අපිට නම් බේරෙන්න බැරි වෙයි මම මැඩම්ට කියනවා කොච්චර අපි මහන්සි වුණත් අපිට මේක ෆැකල්ටි එක බේර ගන්න බෑ. Any questions anyone? මෙතන ඉන්න ළමයි interested හන්දනේ මෙතන ඉන්නේ. හරි නැත්නම් I'm going to leave. This will be uploaded now. Read.